Hello, everyone. This is Dr. Mick here recording the lecture on drugs or medications for seizures and convulsions and epilepsy. So the anti-seizure medications or anti-epileptic meds, AED. So we'll talk about first of all, the pathophysiology and etiology of the seizure attacks and different types of seizures, and then the different types of classifications to treat patients with different types of seizures. So as we define seizure as a sudden transient alteration of brain function caused by or as a result from the abrupt, explosive, disorderly discharge of the changes in neurons in the cerebrum or the brain cells. So the characteristics may involve different levels of motor, sensory, autonomic, psychic signs, or even change in mental status or altered mental status. Patients, when they experience different types of seizures, some scenarios would be a patient would be fully conscious, others semi-conscious, or other cases would be fully unconscious. They lose consciousness for a few for a short amount of time. Convulsions. What is the convulsion? Or convulsions can be tonic-clonic, can be partial, generalized, or unclassified. So the convulsions, when they are tonic-clonic convulsions, then it's like a jerky, contract, relax kind of movement. So these type of movements associated with some seizures, these tonic-clonic type. Now the convulsions, when it's partial, we call it partial or focal seizures, either simple, complex, or secondary generalized. The third type, which is of the type of convulsion seizures, is called generalized seizures. And then the last one, or the fourth one, which is unclassified epileptic seizure. Tonic-clonic, partial or focal, generalized, and the unclassified. Now, the unclassified epileptic seizures, they are idiopathic, which means there is no underlying cause for this specific type of seizure, because unclassified is as an idiopathic. Idiopathic disease means there is no underlying cause for that disease. We don't know why it occurred. The other unclassified type epileptic seizure could be symptomatic or cryptogenic. This will go under the three different types or subclasses will go under the unclassified epileptic seizures: idiopathic, symptomatic, or cryptogenic. The primary seizures are most of them idiopathic or unclassified. About 50 to 75% of all seizures, it's over that primary seizures as idiopathic, which is, in other words, not associated with any identifiable brain lesions or other specific diseases or causes or diagnoses. So it's just idiopathic. And it's unclassified, and it accounts for about 50 up to 75% of all different types of primary seizures. So it cannot be attributed to any specific cause or diagnosis or disease. However, the secondary seizures, so the primary seizures, most of these seizures are idiopathic. And then the secondary seizures, they result from underlying brain lesions, tumors, or trauma to the brain, like head trauma, brain tumors, cancer, lesions, infections, and they may be caused by metabolic disturbances, by extracranial disorders, or head injury. So these are will be listed under the secondary seizures. So we said primary seizures, most of them, up to 75% of all seizures, accounts for up to 75% of all seizures, and it's of that type, idiopathic primary seizures, no associated identifiable brain lesion or disease or cerebral diagnosis. So it cannot be attributed to any specific cause. Secondary seizures, that's when the seizure has resulted or result from the specific disease like brain tumors, brain trauma, head trauma, brain infections, and so forth. So the partial seizures, partial or focal seizures. There are subtypes of this focal or partial seizures. Simple focal seizures, or complex focal seizures, or complex focal seizures with second generalization. And we'll explain more about that in upcoming slides. Now, to the etiology, what are the most common causes for seizure attacks or for seizures? So it's been the etiological factors been divided or identified according to the age group. So the common causes between the age of 20 to 30 years old, most likely is going to be would result from the structural lesions, which is brain lesions, in other words, either due to trauma, like head injury, brain tumors, cancer, and most of the time it's the either benign or malignant, but there is a tumor in the brain. You still call it lesion too, but it's brain tumor, and vascular disease. The common causes after age 50 is due to the cerebrovascular lesions, like a CPA, for example, or stroke, cerebrovascular accident, and metabolic brain tumors. And there is also a familial predisposition, or some families they carry that predisposition in the form of low threshold to seizure-producing stimuli. So they have that familial tendency to develop this disease. Either trauma or disease or high fever sometimes will result in these type of seizures because of that family history and predisposition and tendency due to the that they runs in the family because of their low threshold to seizure producing stimuli. So in the epilepsy, the abnormal neurons, they will undergo spontaneous firing and result in a discharge or neurologic discharge. The firing spreads to adjacent or distant areas of the brain. If activity involves the whole brain, then this is called generalized seizure attack. So generalized seizure occurs when the activity or that abnormal firing in the brain cells involves the whole brain. So the seizure may start or begin as a focal or partial and become generalized. The etiology of seizures can be listed as we list the main etiological factors under the etiology of seizures of all different age groups, different diagnoses, different etiologies. So list them as specific etiological factors will be cerebral lesions, biochemical disorders, cerebral trauma, and epilepsy. Because epilepsy is a condition for which no underlying correctable cause of the disease or of that seizure can be found. And we'll define epilepsy as a condition for which no underlying correctable cause of the seizure can be found. So that's why we can list epilepsy as is one of the etiologies for of seizure. So a seizure can result from either cerebral lesions, biochemical disorders, cerebral trauma, or epilepsy. Because epilepsy, we said, is a condition for which no underlying correctable cause of the disease of the seizure can be found. So we didn't have a specific underlying correctable cause of that seizure. So that is epilepsy. So we listed the different types of partial or focal seizures as simple, complex, or secondary, generalized. Now, the generalized seizures, they can be classified as tonic-clonic, or what is called grand mal. And you can find this in the table. So first of all, the partial seizures, we said it's either simple, partial, complex, partial, and also there is a third class, a subclass of the partial as the secondary generalized. But you can stick to these two, is simple and complex partial. And then under generalized seizures, we have the absence, which is petit mal, the tonic, always called the trap attacks, and tonic-clonic, or what is called the grand mal seizures or tonic-clonic. And then we have other special syndromes that are associated with seizure attacks. Febrile myoclonic and status epilepticus. So when we see status epilepticus, means it's a prolonged seizure attack or multiple seizure attacks within 30 minutes, more than one attack within 30 minutes. So tonic-clonic seizures or grand mal. Let's start with the generalized seizures. These are characterized by loss of consciousness and falling. There is a body stiffness, which is tonic, with subsequent jerky extremities, clonic. Tonic-clonic. That's a grand mal. Patient would be exhibit or show signs of like cyanoses, excessive saliva, tongue or cheek biting may occur too. They bite their cheek or mucous membranes or their tongue. Then after the seizure attack, which is post-ictal phase, which is after seizure attack, patient will have, they are characterized by muscle soreness, so that's very sore and very painful from these multiple repeated tonic-clonic muscle movements, and then fatigue, and patient may sleep after this attack for hours after the ictal or the seizure attack. And they may not feel normal for days after this attack, but they will have no memory of the seizure that they have exhibited or they have experienced the seizure. They cannot recall it. There is no recall of that seizure. The typical absence seizure is petit mal. Typical absence seizure or petit mal. It occurs only in children and rarely into adults or adolescence period or age. It may cease or develop into another type So either it will stop and then, during childhood, may cease, or it may develop into another type of other seizures. Um, Typical symptom of this absence Pittet-Mel seizure is the staring spell for only a few seconds and usually goes unnoticed. It will be like unnoticed. Others won't even realize that that kid or child had this staring spell as a seizure attack. But with these few seconds of staring spells, and it did, the the child will, if they are diagnosed with this Pittet-Mel absence seizure, visually experience this several times during the day. But most of the time, it will go unnoticed by parents or by the people who live with the take care of the child. There is brief loss of consciousness during these steering spell, and it may occur more than 100 times or up to 100 times per day, and that's if untreated. And often will be precipitated or aggravated by the hyperventilation and flashing lights that will precipitate the attacks. Hyperventilation and the flashing lights. Now, the atypical absence seizure which is, we're not going to cover it here because that's not a common type of seizure. The etonic, or drop attacks. Another other names for etonic is called ekinetic or ecstatic. Ekinetic or static or etonic is the same one. It can be interchangeably these three terms used to denote the etonic seizure, and it's usually interchangeably also for used for drop attacks and fainting spells. So this type of seizure involves tonic episode or paroxysmal loss of muscle tone, and the person will fall and after this seizure attack, patient will be very confused, and consciousness usually returns by the time the person hits the ground and can resume normal activity. So there is a great risk here for head injury during this drop attacks. So when we say epileptogenic focus, what is the epileptogenic focus? It's a group of neurons that are hypersensitive to paroxysmal depolarization shift. So there are a group of neurons that are hypersensitive to paroxysmal depolarization shift. And these neurons are easily activated by factors like hyperthermia, by hypoxia or hypoxemia, hypoglycemia, and hyponatremia. These factors may activate this epileptogenic focus to result in or cause this seizure attack. And these factors that may activate these cells, like hyperthermia, high temperature, hypoxia, hypoxemia, hypoglycemia, and hyponatremia. So at this point, to differentiate between the seizures and epilepsy, we can say that seizures, like this is one of the common questions, is what is the difference between seizures and epilepsy? We can say that seizures are a symptom of epilepsy. Epilepsy is the underlying tendency of the brain to produce a sudden burst of electrical energy that will disrupt other brain functions. So, for example, having a single seizure attack does not necessarily mean a person has epilepsy. So epilepsy, on the other hand, we can say that epilepsy is an underlying condition that affects the delicate systems that govern how electrical energy behaves in the brain and making the brain susceptible to recurring seizures. So when the seizure or while any seizure is cause for concern, having a seizure does not by itself mean a person has epilepsy. So in other words, that we cannot say that a person with seizures is we can diagnose them with epilepsy. So like first seizures, like one episode of seizure, only one episode of seizure, due, for example, to high temperature, hyperthermia, or febrile seizures, or non-epileptic events, eclampsia during pregnancy. They all of these are examples of seizures that may not be associated with epilepsy, because this seizure has resulted from either high temperature, hyperthermia, um, or from during pregnancy. So there is a specific reason and cause for the seizure, or it's only happened or occurred only once. So that doesn't mean that the patient or person has epilepsy. So the epilepsy may result from various causes. Can result from uh, metabolic defects, can be congenital, genetic, uh, postnatal trauma, infections, brain tumors, vascular disease, fever, and medications or alcohol abuse. So therapeutic considerations, treatment goals, and treatment options. We'll focus here on the medications or treatments for different types of seizures. So the two major categories of medications or drugs to treat patients with different types of seizures, we have the traditional anti-epileptic drugs or anti-seizure drugs, anti-epileptic or anti-seizure drugs, or it's called AED, anti-epileptic drugs, like phenytoin, carbamazepine, valproic acid, and others. And also we have another group, which is the newer AEDs, anti-epileptic drugs, these new drugs, like gabapentin, uh, and others. We'll go over these medications in a few minutes. So there are two major classifications of drugs to treat patients with epilepsy or with seizure attacks. We said the anti-epileptic drugs, the traditional ones, and then we have the new AEDs. Anti-seizure pharmacotherapy. So the goal for the anti-seizure pharmacotherapy or the anti-epileptic AED to suppress the neuronal activity that is enough to prevent abnormal or repetitive firing of the electrical impulse in the brain cells. So these drugs are going to work on one of the following mechanisms. It's either going to stimulate an influx of chloride ions or will delay the influx of sodium ion, or it will delay the influx of calcium. And the fourth mechanism would be also, which is kind of cutting edge and being studies, which is to antagonize the primary excitatory neurotransmitter glutamate. So the medications or anti-seizure pharmacotherapy will be directed at controlling movement of electrolytes across the neuronal membranes or affecting neurotransmitter balance. So that's all these drugs are going to function or do in terms of the AED drugs or pharmacotherapy are going to be directed at controlling movement of electrolytes across the neuronal membranes or affecting the neurotransmitter balance. So we have different types of examples and exact mechanism for how each of these medications will work in terms of their mechanism of action. So the drugs or medications to treat or that will potentiate the GABA action. For example, we have medications that will potentiate the GABA action. The barbiturates, benzodiazepines, and we have miscellaneous drugs. So we'll go over that. So the GABA, which is the gamma aminobutyric acid, GABA action, which is the medications that will change the action of the GABA, which stands for abbreviation for the gamma aminobutyric acid, which is the GABA. This neurotransmitter is the inhibitory neurotransmitter in the brain. It's the primary inhibitory neurotransmitter in the brain. It does the inhibition in the brain. And its predominant effect of GABA potentiation is CNS depression. So as you potentiate the GABA receptors or neurotransmission, then that will result in CNS depression. So that will be type of treat patients with the seizure attacks. So these drugs that will potentiate the GABA action, which will include barbiturates, benzodiazepines, and miscellaneous drugs. It will suppress the firing ability of the neurons. So these drugs treats seizure attacks, the barbiturates, but there is a low margin for safety. There is high potential for dependence. It may cause profound central nervous system depression. And so barbiturates, we can say that the barbiturates are overall effective against all major seizure types except the absent seizures. An example, phenobarbital, luminol, and primidone or mycilline. And these both are commonly used medications. Phenobarbital and the primidone. Now the benzodiazepines, the indications for benzodiazepines will be good for effective drug to stop the seizures, for absent seizures and myoclonic seizures. Patient may develop tolerance to this medication, and it's one of the most widely used and prescribed medications among all classes. And it's used also we can also prescribe the benzodiazepines for like lorazepam, azathioprine, for anxiety, for spasm of the skeletal muscle spasm. Also, it's very effective to treat patients during the alcohol withdrawal symptoms. So barbiturates, they work by like phenobarbital, very effective anti-epileptic drug, anti-seizure drug, and it works by changing the action of the GABA receptor or the GABA neurotransmitter on the receptor in the brain. Side effects: depression, drowsiness, vitamin deficiencies, laryngospasm. So we have to monitor the patient's condition, and liver and kidney function should be also monitored for this patient while on phenobarbital. The parenteral phenobarb is a soft tissue irritant. So the IM injections may produce a local inflammatory action. The IV administration is rarely used because extravasation may produce tissue necrosis. So the IV administration is rarely used because extravasation may produce tissue necrosis. Different drug schedules, schedule 1 through 5, and each schedule with associated or schedule level with associated abuse potential for physical dependency, and potential for psychological dependency. And we have examples, and we have the therapeutic use for schedule 1 through schedule 5. Schedule 1, which is limited or no therapeutic use, like heroin, LSD, marijuana, and others. And then and that's what we include the schedule 1 and schedule 2. However, schedule 3 and schedule 4, they are used therapeutically. To therapeutic application is okay with prescription. It should be controlled and with prescription. However, the schedule 5, which is the like codeine, for example, cough preparation containing some small dosage of codeine, that's usually used therapeutically without prescription. So the phenobarb is a long-acting barbiturate used for the management or treatment of different types of seizures, and it's also used to promote sleep. It should not be used for pain relief. It's like as part of that pain management, because it may increase patients' sensitivity to pain. So sensitivity to pain may increase due to this disease. I mean, if we use this phenobarbital for pain management, so it's not recommended for pain management. Side effects of phenobarbital. Common side effects will include drowsiness, vitamin deficiencies, especially vitamin D, the folate, B9, and B12, the cyanocobalamin. Cyanocobalamin, which is B12. Laryngospasm also expect a side effect from phenobarbital. With overdose, may cause severe respiratory depression, CNS depression, coma, and death. The drug-drug interaction, the most important thing is that the phenobarb interact with many other drugs. And example of this one would be that it should not be taken with alcohol or other CNS depressants. So the control substances, just to explain the different levels or different scheduled drugs in terms of Schedule 1 through Schedule 5, in the US, the controlled substance is a drug whose use is restricted by the Controlled Substances Act of 1970 and later revisions. There were the 1970 Act, and then there were some revisions right after that. But it was the first time it was enacted was in 1970, which is the Controlled Substances Act. Now, according to this law, drugs that have a significant potential for abuse are placed in these drugs will be placed in 5 categories. So will be listed under 5 categories called schedules. We call it Schedule 1, Schedule 2, Schedule 3, Schedule 4, and Schedule 5. Now, these scheduled drugs are classified according to their potential for abuse. Schedule 1 drugs have the highest potential for drug abuse. Schedule 5 drugs have the lowest or least potential for abuse. Now, Schedule 1 drugs are restricted for use in situations of medical necessity, if all allowed. I mean, if like at all are allowed. Now, they have little or no therapeutic. Now, the Schedule 1, we said that the Schedule 1, they are restricted for use in situations of medical necessity, if at all allowed, and they have little or no therapeutic value or are only intended for research purposes. Now, drugs in the other 4 schedules may be dispensed only in cases in which therapeutic value has been determined. If you have found from evidence-based practice, from research, there is some therapeutic value, it can be prescribed. However, that Schedule 5 is the only one category in which some drugs may be dispensed without prescription because the quantities of the controlled drug are so low that the possibility of causing dependency or dependence is extremely remote. So not all drugs with an abuse potential are regulated or placed into schedules. Like, for example, tobacco, alcohol, other caffeine, they can produce dependence. But they are not, these are significant examples of that, other materials or chemicals or drugs that have the abuse potential, but they are not scheduled drugs. So what is dependence? Dependence is a related term often defined as physiologic or psychologic need for the substance. So we have physical dependence and we have psychological dependence. So physical dependence refers to an altered physical condition caused by the adaptation of the nervous system to repeated drug use. So in this case, when the drug is no longer available, then the individual expresses physical signs of discomfort known as withdrawal symptoms. However, in contrast, when an individual is psychologically independent, there are few signs of physical discomfort when the drug is withdrawn. However, the individual feels an intense, compelling desire to continue drug use. So that's psychological dependence. So benzodiazepines, Schedule 4 drug, or one of the brand names is Valium. Diazepam or Valium. The diazepam is generic name and Valium is the brand name. So the mechanism of action is similar to that of the barbiturate, but it's way faster than the barbiturate. In terms of that, we said that barbiturates are going to um, activate or change the action of the GABA receptor or transmitter at the GABA receptor to control seizures. Drowsiness and dizziness also has a side effect of um, from the diazepam. So the diazepam is an anti-seizure drug. It's the potentiates the GABA receptor, so that's why it's the GABA receptor agonist. So when the drug is used orally, maximum therapeutic effect may take from 1 to 2 weeks. So the tolerance to diazepam may develop after about 4 weeks. And when this drug is given intravenously, so when it's given IV, the effects occur within minutes. And its anticonvulsant effect lasts about 20 minutes only. So when it's given IV for the patients, it's the best drug to stop the active or the ongoing seizure attack. So intravenously given, so that's especially with the status epilepticus, it will work within minutes. The effect will occur within minutes. And then the anticonvulsant effect will last for about 20 minutes. Drug-drug interaction, the diazepam should not be taken with alcohol or with other CNS depressants because of combined sedation effect. Other drug interactions include cimetidine, oral contraceptives, valproic acid. These medications may potentiate diazepam action. It's given with levodopa. It may decrease diazepam action. And also the diazepam increase the level of phenytoin in the bloodstream and may cause phenytoin toxicity. So we should be careful when we give the diazepam to patients who are already on or taking the phenytoin dilantin for seizure attacks on a regular basis. Most of the time, patients will take the phenytoin on a daily basis, once, twice, or 3 times a day. And we should be careful when we administer the diazepam, because we know that the diazepam will increase the level of phenytoin in the bloodstream, and that will result in toxicity. And we said that the phenytoin dilantin level in the blood should be maintained within the therapeutic range, which is 10 to 20. So diazepam, Valium, patient teaching. We also may include the not to stop the drug abruptly. So do not suddenly stop taking the drug. These are part of the patient teaching. Also to take it with food and to report symptoms of fever or sore throat and to report any weight loss and anorexia. Examples of the benzodiazepines. So we have also, so that was the prototype drug. Diazepam was the prototype drug. Other medications that are similar to that drug are going to be, so the highlighted ones, these blue colored ones, are the most important ones. Clonazepam, Klonopin, lorazepam, Ativan, gabapentin, Neurontin, pregabalin, Lyrica, topiramate, or Topamax. So these are the most important ones from the benzodiazepines and other GABA-related drugs. And I have next, and this is the table which identifies specific or the effectiveness of each of these drugs with the specific type of seizure or seizure attack. Like patients with the diazepam will treat all different types of seizures, but not good for the partial seizures. Diazepam is great for generalized seizures and also for myoclonic. Absence seizures is good. It's also effective for tonic-clonic, effective for myoclonic. The gabapentin, it's only effective for partial seizures. So this is why it's important to at least to briefly to know the specifics about the different types of of these seizures, like what is partial and what are expected symptoms and generalized seizures and the myoclonic. So some medications are good for one or two types, and others would be only effective for just one specific seizure, a type of seizure. The high dentoins, in which that phenytoin dilantin belong to, that these are the medications that were, the mechanism of action is to desensitize the sodium channels. That's the exact mechanism how the phenytoin or dilantin works, by desensitizing the sodium channel. And it can treat all types of epilepsy except the absence seizures. Adverse effects of phenytoin, dysrhythmia, like Brady or VFib, severe hypotension, and hyperglycemia. So patients with diabetes have to be careful. We have to monitor their blood sugars. We have to be, there should be a caution from prescribing the phenytoin, but if that's the only, the last resort, or we have to prescribe it, then we have to monitor the glucose levels, blood glucose levels. So severe CNS reaction include headache, nystagmus, ataxia, confusion, slurred speech, paradoxical nervousness, twitching, insomnia. When dilantin is given intravenous IV, we should be careful that to start a cardiac monitor for the patient. So careful cardiac monitoring is needed during the and after administering the IV dilantin because of identified or known expected side effects of the phenytoin, especially the IV, that may result in dysrhythmias, especially bradycardia and ventricular fibrillation. So the dilantin comes in different formulations, tablets, Infitab, IV, and capsules. So phenytoin is a gastric irritant, so it should be given with or immediately after a meal to decrease gastric upset. Adverse effects, we identified adverse effects like nystagmus, sedation, ataxia, diplopia, and one of the most important adverse effects of dilantin is gingival hyperplasia. Gingival hyperplasia of the gum tissue, and that would most likely would result when the patient is not compliant with the mouth care. But also, side effects also may include skin rash, and interactions. We said that the drug may interact with oral contraceptives, steroids, warfarin, that it will decrease, the drug will decrease the effect of the oral contraceptives or warfarin, Coumadin, or steroids. But the drug is given with the and other drugs only increase its effect. For example, if we give the phenytoin with diazepam or with cimetidine, valproic acid, so that will increase the level of these medications, increase potentially the level of diazepam, cimetidine, alcohol, valproic acid. So some medications that the drug will increase their other medications intensity or effect, and when it's given with other medications, this diazepam may decrease. So it may increase with some medications and may increase with decrease with other medications. It depends on the meds. The first one or list of medications that the effect of these drugs will decrease, like oral contraceptives, Coumadin, warfarin, sodium, and steroids. But when it's given with diazepam, isoniazid, cimetidine, alcohol, valproic acid, it may increase the levels of these meds. That's why it's called the drug-drug interaction. The other drug is the valproic acid, which is dipakine. And its mechanism of action is to desensitize the sodium channels. That's how it's an effective drug to control the seizure attacks. So valproic acid is a GI irritant, so we advise patients not to chew extended release tablets because mouth mucous membranes or the mouth soreness will occur. So that could result in soreness of the mouth, buccal cells or tissues and mucous membranes in the mouth will be sore from chewing the extended release tablets. So should advise patients not to chew on these extended release tablets. Now, to not mix the valproic acid syrup with carbonated beverages because it will trigger the immediate release of the drug, which will cause, again, severe mouth and throat irritation. So valproic acid, which is a dipakine, is a phenytoin-like drug because it works in the same exact mechanism of action on the sodium channels. So one of the most serious side effects of this drug is the liver function deterioration or liver impairment. So we have to monitor the patient's liver function tests frequently. Periodic or frequent liver function tests should be performed to identify any changes to the hepatic function due to the use of this drug. So the liver function tests should be performed prior to the treatment as a baseline and at specific intervals during the first 6 months of treatment. Because the valproic acid, it can produce the hepatic and also it may affect the pancreas and result in life-threatening pancreatitis. The valproic acid, so before we go to carbamazepine, so valproic acid, other indications for valproic acid. So valproic acid, Papakin, is good for effective for seizure disorders, for bipolar disorders, and also sometimes prescribed for migraine headache. Side effects, the main side effects are include the GI effects or upset stomach, hepatotoxicity, which is liver failure, pancreatitis, and also it could result in teratogenic effects. Gastrointestinal effect or GI effect, including nausea, vomiting, indigestion, are common with valproic acid. But that we can minimize these symptoms, GI effect or symptoms, by taking the drug with food, or take the drug as an enteric-coated product. The carbamazepine, which is Tegretol, very effective for tonic-clonic and partial seizures. So Tegretol or carbamazepine also is effective as, other than for epilepsy or seizures, also can be used for bipolar disorders and for a trigeminal and a glossopharyngeal neuralgias. Hematologic effects like leukopenia, anemia, thrombocytopenia, leukopenia, which is decreased white blood cells, thrombocytopenia, low platelet counts. There's another group of medications, succinimides, to treat seizures. They suppress seizure attacks by delaying the calcium influx into neurons. And they are very effective for absent seizures. Most commonly prescribed drug from this class is the Zarantan and the brand name, but the generic name is the ethosuximide. Ethosuximide or Zarantan is the most commonly prescribed drug in this class. And the last one, which is the amino acid compounds, like the acetazolamide and glycosamide, Diamox, and the Vimpat. Ethosamide or Zarontin as one of the most common prescribed drug from the succinimides. It's the preferred drug for managing absence seizure. And it depends, it depresses the activity of the neurons and the motor cortex by elevating the neuron threshold. Also, other than it depresses the activity of neurons and the motor cortex, but also it is also, we can add one more effectiveness, or I'm sorry, we can say that it is usually not effective to treat patients with psychomotor or tonic-clonic seizures. So patients with tonic-clonic seizures, it's not recommended that we treat them with this Zarontin or ethosuximide drug. So it's very effective for absence seizures. It is usually ineffective against the psychomotor or tonic-clonic seizures. However, it may be given in combination with other medications that better treat these conditions. And it's always available in tablet and flavor syrup formulations. So for ethoxazimide or Zarontin, do not abruptly, do not suddenly withdraw this medication, because doing so may induce tonic-clonic seizures. You may induce tonic-clonic seizure if this drug is stopped abruptly or suddenly.